Hello, you're welcome to my platform. I am Dr. Sandra and I am a surgeon. I hope you become aware and sensitized about the different surgical conditions. I am so excited to introduce to you my newly launched electrical appliance online store. It has high quality refrigerators, it has washing machines, microwaves, air fryers. It has ranges too. You can basically be cooking on top and you're baking something on the bottom. It also has these 5-in-1 food processors. Please support the work that I am doing on this platform by purchasing any of these items. Please place your order today by reaching out to me via WhatsApp or via a call on my numbers on the screen, and then your order will be delivered to you. Deliveries can be done to all parts of Uganda, but in the future, as the business grows, I'll be able to ship to those outside of Uganda.
Please place your order now.
Today's video is another type of pneumonia, a lung infection, and this type is different from the pneumonia that I talked about earlier, that is the ventilator-associated pneumonia. Although this type also occurs in a hospital setting or in a healthcare setting, and it usually occurs in individuals who are left to breathe on their own or who are breathing on their own, and they are not being assisted to breathe. For example, using a mechanical ventilator, a machine that assists certain patients to breathe. This type of pneumonia is called the non-ventilator associated hospital-acquired pneumonia. The non-ventilator associated hospital-acquired pneumonia is a lung infection, and it usually occurs at least 48 hours after admission to the hospital or to a healthcare setting, for example, a nursing home. And it usually occurs in individuals who are not on a mechanical ventilator. These individuals are usually able to breathe on their own, or they are left to breathe on their own. The non-ventilator associated hospital-acquired pneumonia is more common in comparison to the ventilator-associated pneumonia. About 30% of the patients that develop the non-ventilator-associated hospital-acquired pneumonia tend to die, and those that survive tend to stay longer in the hospital. They tend to have a longer hospitalization. The non-ventilator associated hospital-acquired pneumonia usually occurs as a result of infection by certain germs. For example, the bacteria, the fungi, and the viruses. The commonest bacteria that cause the non-ventilator associated hospital-acquired pneumonia include Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenza, the methicillin susceptible Staphylococcus aureus, certain multi-drug resistant bacteria, for example, the methicillin resistant Staphylococcus aureus, the Pseudomonas aeruginosa, the Actinobacter species, Klebsiella pneumoniae, Escherichia coli, Serratia marcescens, and Stenotrophomonas maltophilia. In rare cases, non-ventilator associated hospital-acquired pneumonia can also be caused by viruses, for example, the respiratory syncytial virus and the influenza virus. It can also be caused by fungi, for example, aspergillosis. In a setting where the patient has altered levels of consciousness, for some reason, maybe they have been sedated with some medications, or they have a problem with their brain. For example, they got traumatic brain injury as a result of physical trauma to their head, or if they have increased secretions, for example, saliva and mucus in their mouth and throat, or if they have overgrowth of bacteria within their mouth. For some reason, maybe they have a poor oral hygiene. The secretions, for example, mucus or saliva that also contain the bacteria, can find their way into the lungs, and they might cause infection within the lungs, especially if the patient is not fully awake. That is how they end up getting the non-ventilator associated hospital-acquired pneumonia. The bacteria can also find their way into the lungs if this individual also had an infection elsewhere within their body, for example, the genitourinary tract.
That is your reproductive system and also the system that forms urine.
So the bacteria can be transported by blood and they can find their way into the lungs, and that is how they can end up causing the non-ventilator associated hospital-acquired pneumonia. If the affected individual coughs, they can release respiratory droplets. These are usually small particles of the saliva and the mucus, and they also contain the bacteria. So if there is anyone that is around that patient that has coughed, for example, a relative of that patient, a healthcare provider, other patients, they can breathe in those respiratory droplets, those small particles of the mucus and the saliva containing the bacteria, and that way these droplets can be introduced into their respiratory tract, and they can find their way deep into the lungs, and these patients can also end up getting the non-ventilator associated hospital-acquired pneumonia. Which individuals are more susceptible to getting the non-ventilator associated hospital-acquired pneumonia? Individuals that have an altered mental state. They are not fully alert for some reason. Maybe they have been sedated with some medications, or they are intoxicated with alcohol, or these individuals might even be having a problem with their brain for some reason. Maybe they got a traumatic brain injury as a result of physical trauma to their head. Individuals that have chronic respiratory diseases, for example, the chronic obstructive pulmonary disease, COPD. Individuals that have a poor oral hygiene. Individuals who cannot get out of bed for some reason. Maybe they are in too much pain, or they are disabled. Very young individuals, especially the premature babies, and also the elderly, those more than 65 years of age. Individuals that have chronic conditions, for example, chronic obstructive pulmonary disease, kidney disease, liver disease, and heart disease. Individuals that have a low immunity for some reason. Maybe they have HIV, they have diabetes mellitus, they are on steroids, or they are on anti-rejection drugs. Maybe they underwent an organ transplantation. Individuals that have difficulty in swallowing, as well as individuals that are on medications that reduce the secretions of the stomach. For example, the proton pump inhibitors like omeprazole, pantoprazole, rabeprazole, and lansoprazole. How do you know if you or your loved ones have the non-ventilator associated hospital-acquired pneumonia? There might be fevers, that is an increase in the body temperatures, chills, that is a feeling of coldness. There will also be productive cough. The sputum that will come out when the patient coughs will either be green or it will be yellowish in color. It will look like pus. Chest pain, especially if the individual coughs or if they take a deep breath. Tachycardia, that is an increase in the pulse rate. Nausea and vomiting. Nausea, by the way, is that feeling as though you want to vomit. There will also be headaches and anorexia, that is loss of appetite. However, in elderly individuals, those that are 65 years and above, they'll present differently. For example, they might only present with one sign. They can present with confusion, but they can also present with a drop in the body temperatures instead of them having an increase in the body temperatures. The elderly individuals can also just have a drop in their appetite, loss of appetite. They might not have all the other signs and symptoms that I talked about earlier. They might just present with only these or just one of these. This means that in the elderly, it is very, very likely that the non-ventilator associated hospital-acquired pneumonia can go undiagnosed. So it is very important that the healthcare providers be vigilant in looking out for the atypical presentation of the non-ventilator associated hospital-acquired pneumonia. How do we assess or evaluate the patients for the non-ventilator associated hospital-acquired pneumonia? We usually do clinical assessment, chest radiological assessment, and laboratory and microbiological assessment. In the clinical assessment of the non-ventilator associated hospital-acquired pneumonia, we always look out for the signs and symptoms. For example, we look out for new or worsening increase or a drop in the body temperatures. We also look out for cough, and usually the cough has purulent sputum, yellowish sputum. It is pus-like, but also sometimes it can be green in color. We also look out for new onset or worsening confusion, especially in the elderly. We also look out for low oxygenation, and this is usually evidenced by a low peripheral saturation of oxygen, less than 90%. The other part of assessment is the chest radiological assessment. We usually start with a chest x-ray, and we always look out for new or persistent alveolar shadowing, and this is usually consistent with pneumonia. We can also do a chest CT scan, especially if the chest x-ray was unclear or it wasn't conclusive. The third evaluation or assessment tool that we can employ in the evaluation of these patients is the laboratory and microbiological assessment. We can do a complete blood count, and this can reveal a low or a high white blood cell count. We can also do arterial blood gas analysis. We can also carry out a nucleic acid amplification test, for example, a PCR. We can also carry out other tests, for example, ESR, CRP, procalcitonin. We can also do a urinary antigen test, especially for some species of bacteria, for example, the Legionella species. We can also carry out sputum analysis. The patient can avail us with a sample of their sputum, and we can carry out some tests. We can do gram staining, we can do culture of the sputum. And when we culture the sputum, it can help us to ascertain the pathogen, the germ that is causing this non-ventilator associated hospital-acquired pneumonia. This way, we can also target our medications to that pathogen or to that germ, for example, the bacteria. We can also do a blood culture where we take off a sample of the blood and we can culture it, and this can also help us to isolate or to identify the pathogen or the germ, for example, the bacteria that is causing this non-ventilator associated hospital-acquired pneumonia. However, before we can take off the samples for sputum analysis and blood cultures, we have to make sure that the patient has not been given antibiotics yet. So the samples are usually taken off before any antibiotic therapy has been initiated. How do we end up diagnosing a patient with non-ventilator associated hospital-acquired pneumonia? We usually end up diagnosing a patient with the non-ventilator associated hospital-acquired pneumonia by using two assessment tools. That is the chest radiological assessment and the clinical assessment. We have to use these two assessment tools in tandem because we cannot only rely on the chest radiological assessment, the chest imaging. This is because there are other conditions that can mimic or that look like pneumonia on the chest radiographs or on the chest images. For example, the atelectasis, that is lung collapse, pulmonary edema, and pulmonary embolism. So it is important that we correlate the results of the chest imaging with the clinical assessment. For example, the respiratory symptoms. On the chest radiological assessment or the chest X-ray or CT scan, we are going to look out for a new or worsening lung shadowing or infiltrate alveolar shadowing. So we have to look out for radiological evidence of these on chest X-ray or CT scan. Like I told you earlier, the radiological assessment or the radiological tool or evidence has to be used in tandem with the clinical evidence, and you have to have at least two of the following to end up diagnosing a patient with the non-ventilator associated hospital-acquired pneumonia. There can be a new fever, that is a body temperature of more than 38 degrees Celsius, or a new drop in the body temperatures, that is less than 36 degrees Celsius. There also has to be a purulent secretions coming out of the airway, that is pus-like secretions. For example, sputum and mucus coming out of the airway, and this is sometimes after coughing. There can also be a drop in the peripheral oxygen saturation, and this usually indicates worsening oxygenation within the blood, meaning there is not enough oxygen that is taken into the blood from the lungs because the lungs are infected, so they cannot execute their duty of taking oxygen from the environment into the blood. There can also be an increase in the white blood cell count or a decrease in the white blood cell count. How do we treat individuals that have the non-ventilator associated hospital-acquired pneumonia? We usually employ the antimicrobial agents, and the type of the antimicrobial agent that we employ is dependent on the type of pathogen or the germ that has caused the non-ventilator associated hospital-acquired pneumonia in that particular patient. Because in majority of the cases, the non-ventilator associated hospital-acquired pneumonia is caused by bacteria, we usually start these patients on broad-spectrum intravenous antibiotics. However, before we start them on these medications, we have to take off a sample of the sputum, and this can be taken to the laboratory for culture, such that when the results come back, we can now target our antibiotic therapy or antimicrobial therapy to that particular pathogen or germ that will be isolated in the culture of the sputum. In patients that have risk factors for certain bacteria, for example, the methicillin-resistant Staphylococcus aureus and Pseudomonas, especially in patients that have had previous hospitalization or previous antibiotic use. So in patients that we are suspecting to be having the methicillin-resistant Staphylococcus aureus as the cause, we usually give these patients vancomycin. However, in patients that we are suspecting to be having Pseudomonas, we always give Parathylene tazobactam. We usually use this as we wait for the results from the culture and sensitivity of the sputum to come back. And then when the results come back, we can target our medications towards the bacteria or the pathogen or the germ that has been isolated from the sputum culture. However, for individuals who don't have any risk factors for the methicillin-resistant Staphylococcus aureus and Pseudomonas, we can still employ the piperacillin tazobactam, cefepime, imipenem, meropenem, and sometimes levofloxacin. And again, these are usually given before the results from the culture and sensitivity of the sputum come back. But once the results come back, we can always target our medications dependent on what pathogen or what germ, for example bacteria, has been isolated from the sputum culture. We usually treat these patients for about 7 to 8 days, especially if there is no evidence of resistant bacteria that was isolated, for example the methicillin-resistant Staphylococcus aureus, and also if these patients are showing signs of recovery, if the response to treatment is very fast. However, in a setting where Staphylococcus aureus has been isolated, we usually treat these patients for a minimum of 2 weeks, that is 14 days. We also encourage fluid and nutritional support. These patients have to drink a lot of water, especially warm water, a lot of fluids, juice, especially natural juice. And they also have to eat a balanced diet. All of these help them to recover very fast. The fluids help them to be rehydrated, and the nutrients from the balanced diet help them to recover. We also encourage physiotherapy, and this includes walking around, getting out of bed such that the patient can walk around, but it can also include chest physiotherapy. Chest physiotherapy is a breathing exercise, and it helps to clear the secretions from the patient's chest such that the patient can heal faster, because when the secretions are cleared, also oxygenation is enhanced. The amount of oxygen that the lungs will be able to take into the bloodstream is also increased, it is enhanced. We also have to give these patients oxygen therapy. Oxygen therapy helps to increase the amount of oxygen that is taken into the blood, because sometimes these patients have a low peripheral oxygen saturation, less than 90%. So when we give them oxygen, it can also increase the amount of oxygen that goes to the bloodstream. How can we prevent the non-ventilator associated hospital-acquired pneumonia? Please exercise proper oral care in these patients. For example, if you are a relative of this patient that is in the hospital, most likely the patient is not in a good mental state or they are not fully awake. Ensure that you clean their mouth, because remember I told you that when the mouth is dirty, bacteria can easily go down into the airway and then it can enter into the lungs, and this is how these patients end up with the non-ventilator associated hospital-acquired pneumonia. And of course, if they are fully awake, let them brush their teeth every after a meal. It is also very important that patients get out of bed. If a patient gets out of bed and they walk around, they will not get the non-ventilator-associated hospital-acquired pneumonia. So encourage your patients to get out of bed as fast and as soon as possible and as frequent as possible. Please always ensure that the beds of the patients are always elevated at either 30 degrees or 45 degrees. This can help them not aspirate, or the secretions or the mucus and the saliva will be prevented from entering into the airway and then into the lungs. Patients that have an altered mental state, for example, they are not fully awake, we always have to insert a nasogastric tube. Insertion of the nasogastric tube can help to decompress the stomach such that the contents of the stomach don't get into the lungs. We should also minimize the use of sedative agents, especially in patients who don't need them, because when these patients are sedated, their mental status will also be altered, so they can easily aspirate, or they can easily have secretions getting into their airway and then into the lungs. We should also encourage patients to do chest physiotherapy by taking deep breaths. Chest physiotherapy can help to expand the lungs and to clear the secretions from the patient's airway. We can also employ incentive spirometry. Incentive spirometry can help to expand the patient's lungs.
Please also wear face masks while in a healthcare setting.
That is what I had for you. Thank you so much for watching and listening. Please share, like, comment and subscribe. Also hit the notification bell such that you can get notified whenever I upload a video. Please also support the work that I am doing on this platform by purchasing any of my items from my electrical appliance online store. Please place your order today by reaching out to me via WhatsApp or via a call on my numbers on the screen, and then your order will be delivered to you. Deliveries can be done to all parts of Uganda at a free cost. You don't have to pay for the delivery. But in the future, I'll be able to ship to those outside of Uganda. Thank you so much, and I'll see you in my next video. Bye.